The broadcast is now starting. All attendees are in listen-only mode.
Greetings, friends. Good afternoon to those of you in the central U.S. and East Coast. Good morning to those of you in the West, and rise and shine to our friends in Hawaii. Welcome to our first webinar in 2018, Caring and Coding for Malnutrition. My name is Bernard Hernandez, and I am Chief Information Officer with DM&A, and I'll be your host today. We are so very excited to have you with us today. We have almost 700 of you joining us from all over the US and Canada. This only shows how important and valuable today's topic is. Just a few housekeeping logistics before we begin. During the webinar, the phones will be on mute and you will be in listen-only mode. There will be a brief question and answer session at the end of the presentation. In order to ask a question, all you have to do is type it in using the questions box in your GoToWebinar control panel. So please take a second to locate that. You can type a question anytime during the webinar, and we will answer as many as we can during the Q&A. Those questions that we don't get to, we will reply via email after the webinar. You should have received a handout link in your email from me. You can also download the handout PDF from your control panel. If for some reason you can't find it, type me a question or email webinars@destination10.com and we'll send the handout over to you. I am so very excited to introduce our very special guest, the one and only Sandy Routhier. Sandy is a health information management and coding professional with more than 30 years of experience, with a strong emphasis on operations, inpatient coding and reimbursement, medical record documentation requirements, ICD-10 electronic records, regulatory and accreditation requirements. She is a registered health information administrator, certified coding specialist, certified documentation improvement practitioner, and approved ICD-10 CM-PCS trainer and ambassador through the American Health Information Association. Sandy is currently the VP of Revenue Integrity for CloudMed Solutions. CloudMed provides a unique full coverage software and auditing solution to assure the accuracy of coding and documentation on inpatient cases. In her role as an independent consultant, Sandy performs inpatient MS-DRG validation and coding audits, verifying the quality of coded data and supporting clinical documentation and making recommendations for improvements. Sandy provides education to coding professionals, CDI staff, and physicians. Sandy has a love for continuing education in our ever-changing healthcare environment and a passion for our profession. It is also my distinct pleasure to introduce our other speaker today, my friend Michelle Mathura. Michelle joined the DM&A team and coach. As director, she leads the nutrition division team in providing education, coaching, and support to hospitals all over the country. She provides our clients with the right tools to improve the overall nutrition care process, documentation, reimbursement, and patient care. Michelle holds a bachelor's degree in food, nutrition, and dietetics with a minor in chemistry from North Dakota State University. She is a registered dietitian and a certified diabetes educator, but most importantly, she is a wife to Randall and a mother to their beautiful one-year-old daughter, Lillian. So without further ado, please welcome Michelle. Take it away, Michelle.
Thank you, Bernard, and thank you everyone for joining us today. Sandy and I are so excited for just the outcome and the turnout for this webinar today. We know it's a very important topic for everyone listening, just for you showing up. And so first of all, I want to thank you. Thank you for taking the time to be here today. You're carrying the torch for your profession, for your patients, and for your hospital. You're making a difference with your passion, your leadership, best practices in mind, business-minded, caring, and just making a difference in your hospital for your patient care, for your profession, being the change maker. And I think about that in all that we do in the jobs that we have, but also on the subject of malnutrition. It's one that we see, again, that everyone on this webinar is very passionate about and wants to understand more and learn more to not only help their patients and their facility, but to help understand, to provide the best practice care and to understand the best for their patients. And so you are here for your patients, your profession, your hospital. So hats off to you. Thank you for being here today. So I want to get started with just sharing a little bit about the nutrition division. This is, I want to say, our third or fourth webinar this year, and we're very excited to be able to have educational webinar series. As Bernard mentioned, we provide education and training and coaching to dietitians, clinicians, and hospitals across the country. And our focus is on inpatient nutrition services, outpatient diabetes, self-management education, and also we provide telenutrition support. The malnutrition education and training program falls within the inpatient and outpatient services. And so we've been really focused on that for the last 8 years and have just enjoyed coaching dietitians and working with them with their teams and on patient floors, and working with CDS and coding teams and just all the clinicians, physicians, providers, nurses, and the patients across the country. And so we're happy to be able to present with Sandy today and just share experience there. And this is the service that we provide to hospitals, like I said, across the country, any size. So if you're interested in more, you'll be able to, contact us for that and, just get some good information today. Our malnutrition education and training program, this is an incredible amount of information you'll be getting today, and is a huge piece of what we do on site as well in terms of data tracking. It is an on-site nutrition-focused physical assessment training program as well. That's tied into the education and training program that we do focus on malnutrition. And just like the torch was carried earlier, it's a dietitian-driven program. So you are the leaders. We are there to coach and support you. And I know I've talked with many, many dietitians across the country just recently, and over the last year, the last 5 years, everybody's doing something related to malnutrition, whether it's using the characteristics, the guidelines, just, joining webinars like today, talking with their coding, their CDI steps. So it's great to see that we've all taken steps forward to do best practice. And that's really the most important thing, is to know and do and be trained on and feel confident in providing the best practice we can in our world of nutrition, of screening and assessments and care planning. And really, coming together, and maybe some of you are there today with your CDI and coding staff members and listening together and just bridging those gaps so that we can provide the best for our patients. The value and the purpose of a malnutrition program, and this is, again, one big piece of the puzzle when it comes to really the foundation of keeping your malnutrition program going and the efforts and resources, is we have to provide data to show our value and worth. We can provide our best practice screening assessments. We can be doing the nutrition-focused physical assessment with our patients. We can be communicating with physicians, getting everything coded, but we need to have that data follow-up reporting with that. And so with that, we're able to show, in addition to the great care we provide on the floor, our value to the hospital, but also to the patients. And so a focused program, which many of you are doing, have, or have been having for years, can show the improved quality of patient care. We help provide the best training and tools to effectively implement your evidence-based guidelines. And so these are all things that we're focusing on coaching, and part of a huge reason on why we're sharing this information today is that this is the big need that we've seen in the last year. People need to understand more about coding denials, how to respond to that, and recovery audits. The program helps focus on and elevates the role of the dietitian in the healthcare setting and the inpatient setting, and again, promotes collaboration and team integration with our other interdisciplinary team members that we work with on a day-to-day basis. So the dietitians being the leader in the malnutrition program, so important, and not just for the first year you're focused on it, but for every year to come. And also everything improves the financial health of the hospital, which you'll learn more about today. As many of you know, malnutrition is a global prevalence of 25 to 50%. We'll see different statistics across the country. We see 25 to 50% hanging out there between 40 and 50% when we're just looking at when the dietitians nutritionally diagnose malnutrition. But when we're looking at global prevalence of malnutrition, 25 to 50% of your patients. So think about the patients that you're seen in your hospitals every day if you're not currently using the malnutrition characteristics from the Academy in Aspen, or maybe you're using part of them, or maybe you're using the whole thing. Do you think you're seeing that many patients? And if you are these patients getting diagnosed by your physicians, and then in turn, are they getting coded? There's an estimated 20 million children under the age of 5 worldwide that are severely undernourished as well. We can identify malnutrition, and the most important thing then, once we identify it, is to communicate and care for it. Because it's a common worldwide problem, we will see it in all of our hospitals across the country. And when malnutrition is identified, the next step is to provide the best intervention and plan of care. We've been able to see this grow and grow every year working with hospitals across the country, and it's really exciting for me to see and for our team to see the discharges, interventions that are going on out there, and the different types of discharge planning and different interventions we're sending patients home with. Because we know that malnourished patients have poorer health-related outcomes than our malnourished counterparts. So our interventions make a big difference. So before we dig into the coding and the documentation and coding piece of today, I just wanted to briefly go over the best practices. When I speak of best practice, and we talk about that today in our webinar, when we think about best practice nutrition screen, we want a validated screening tool that identifies malnutrition. And the tool that we use within our malnutrition education and training program, when we provide coaching on-site to facilities, is we go over and use the MST tool by Marie Ferguson. And that tool has been validated by the Evidence Analysis Library, and it's a 3-question tool. I should say a two-question tool with one question has 2 parts to it, and it works really well. So always, make sure that you're using an evidence-based tool for your screening, because you want to pick up all of those patients that need screening. And then we're looking at our nutrition assessment. And so when you're providing the nutrition assessment, most everybody on this webinar probably is using the Academy in Aspen's malnutrition characteristics, which is great. Make sure that your dietitian team has the competency and the confidence, and they have been trained with their patients on the nutrition-focused physical assessment. Because that is a huge piece of the characteristics, and it really helps provide that clinical validation, which Sandy will talk about today. But it gives us, the dietitian, even more information about that patient's overall nutrition health. And then we provide the best intervention on an inpatient and outpatient focus. We always should be thinking about, in our first visit with that patient, once we understand why they're there, and once we've assessed them for malnutrition and provided that nutrition assessment, how did they get here? Because if they're coming in with malnutrition, then we should be thinking about what is that outpatient intervention we want to provide for home, in addition to our inpatient intervention. So we always want to be thinking about that ahead of time. And then working with our interdisciplinary team on the care plan and discharge. So we bring up this first as the foundation, because once we have all of this in place and we're providing a great documentation and we're sending it to our physicians, then we're getting it into the chart. Most of us have worked on some kind of a template or communication tool within the electronic health record to get that documentation in on malnutrition, and we're getting our nutrition diagnosis in there. And then from there, we're hoping that the physician does diagnose as well, and is using the documentation that we have provided to document malnutrition. And from there, I will pass it on to you, Sandy, and you can start sharing about coding for malnutrition.
Thank you very much, Michelle. And I'll just warn everyone, I've been fighting a cold, so a little bit of a raspy voice here, but definitely much better than last week. And if I go on mute for a second, it's just because I've had a little coughing attack. So, but I am so happy to be here today with Michelle and her team to participate in this web presentation for you all. We're going to dive in first and look at the codes for malnutrition that are available in our current ICD-10 CM classification system, which is what we use for assigning diagnosis codes, which calculates then into our DRGs for inpatient reimbursement. So in ICD-10, here are the codes that are available related to malnutrition. And, they all start with the letter E in that category of codes there from E40 to E46. And you can see that malnutrition has the capability to be further specified as mild, moderate, or severe for the severity. And also, we do have an unspecified code there, E46. In that middle column there, you'll see what's referred to as the status of the code. In ICD-10, as we did in ICD-9 under the Medicare's MSDRG reimbursement methodology for inpatients, is certain diagnoses, when there are secondary diagnoses, can have a more of a weight associated with them that equates to higher reimbursement. So that's referred to as a CC or an MCC status. And so those are indicated there on the screen as well. CC means that, you know, there's going to be some improvement in the DRG payment because there's a complication or comorbidity on the case. And then an MCC is a major complication or comorbidity, and that really, you know, has great potential to increase reimbursement. And so getting to that severe malnutrition severity is really where we see some higher weight DRG impact, but also, you know, if it's the only MCC on a case, there's no other MCC conditions associated with that inpatient encounter, that could put that case at risk of a recovery audit activity from the payers, because they know that I just have one MCC on a case, and if I turn that one MCC over, now I've got, you know, a refund coming back to me as a payer because I now just proved that one MCC diagnosis on a case. So we kind of think of severe protein calorie malnutrition as a lone MCC, as a high-risk problem-prone diagnosis on inpatient encounters. You can also see there's some additional diagnosis codes there with MCC status, which we should rarely, if ever, see on an inpatient case, such as kwashiorkor or the nutritional marasmus. I do want to mention, too, that you can see that emaciation due to malnutrition also codes to that E41 for nutritional marasmus based on indexing, but we have some coding clinic advice that tells us, you know, that we need to reconsider that code assignment if that was the diagnosis that was documented in the medical record. In that final column there, we have the severity of illness and risk of mortality, and that really equates to another DRG reimbursement methodology called APR DRGs. We see that many of our state Medicaid plans use that inpatient reimbursement methodology versus the MSDRG reimbursement that uses the CCs and MCCs. So in that case, what really drives reimbursement is severity of illness and risk of mortality. So that's what those scores are there, and the scores are 1 to 4. So the higher the severity of illness, the potential to impact the reimbursement on the case to a higher reimbursement as the SOI improves from 1 to 4. The risk of mortality is more about comparative data because APR DRGs are really risk adjusted and they take into account severity. You know, it's used for a lot of comparative data, whether it's being used for reimbursement or not. So, for example, if you have a patient who expires in a hospital, you would hope that their risk of mortality was maxed out at 4, you know, versus a patient that was at really low risk of mortality having expired during an inpatient encounter. So that's used for a lot of mortality studies as well. Let's go on to the next slide, Michelle. Again, these are the reimbursement methodologies that cover most of the reimbursement for inpatient hospitalizations. We've been on the DRG reimbursement system since the early 80s. We're on group reversion 35 right now. I've been around for all of them. And, you know, there was some significant changes made along the way, definitely some improvements. But the MSDRGs is the most prevalent. That's the Medicare severity adjusted DRGs there that take into account the CCs and the MCCs. And then the APR DRGs are mostly the Medicaids and some commercial payers, like, you know, for example, the state of Nebraska their Blue Cross Blue Shield pays on APR DRGs. And some states are really heavy in APR DRGs, like Medi-Cal in California or New York, for example. So just to illustrate the impact of picking up diagnoses that have CC or MCC status in the MSDRG world is, this case is an encounter where the patient's in the hospital for a lung cancer. And so if the patient had no other conditions that were of CC or MCC status, the DRG in this case would be 182 for the respiratory neoplasm, but you can see that the description there is without a CC or an MCC. And then how Medicare calculates the reimbursement for DRGs is it takes what's referred to as the relative weight, which is highlighted in yellow there, 0.8449, and it multiplies it by the hospital's blended rate. So every hospital has a unique payment rate based on whether they're a teaching hospital, a rural sole community provider hospital, whether they're in California or Northern Michigan, what the wage index is. And the reason there's this really, really complex calculation, but every hospital every October gets this rate that there is assigned to them. And so it's that rate, and I'm using, for example, $7,000 times that relative weight of 0.8449 equals what the expected reimbursement would be for the DRG on that inpatient encounter. So again, this is a neoplasm of the lung case without any complications or comorbidities. So if going on to the next slide now, we can see the impact by adding a CC diagnoses, which is in this case the E44.1, the mild protein calorie malnutrition. When you add that diagnosis to the case, you can see now the DRG shifts to 181, and the weight of that DRG now with a CC is over 1.1561. And when you multiply that by the blended rate, now we can see that the reimbursement has improved from over $2,000. So we went from $5,914 to $8,092 expected reimbursement by the addition of that CC diagnoses. Again, when you have a lone CC on a case, it can put a case at risk. In this case, it's malnutrition, but any lone CC or lone MCC on a case, it is a potential target for recovery audit activity. So, to take this example one step further and say that malnutrition was further specified as severe protein calorie malnutrition, now we've moved to DRG 180, and this DRG is referred to as a triplet because it can be impacted by a CC or an MCC. In this case, the MCC of severe protein calorie malnutrition, E43, and now the relative weight is 1.6894. Multiply that by the hospital's $7,000 blended rate, and now our reimbursement is well over $11,000. So that you can see that the reimbursement has actually doubled from the initial DRG that did not have a CC or an MCC, with the addition of that severe malnutrition as an MCC. Really improves the payment on the case. And the whole idea behind this reimbursement methodology is, as patients are sicker, as they consume more resources during the care of those patients, that they should be compensated for that from their payers. So this is the MSDRG methodology for doing that. Now we'll contrast that with APR DRGs, which utilizes severity of illness and risk of mortality. In this case, you can see, again, this is that lung cancer case, and without any other secondary diagnoses. APR DRGs are a little bit different in the fact that there's diagnoses that do not have CC or MCC status that can improve severity of illness and risk of mortality on a case. But in this case, we're going to keep all the codes the same, so we can contrast the two payment methodologies. So in this case, the APR DRG is respiratory malignancy 136. And again, all these cases will stay in 136 because we're keeping that principal diagnosis the same, but we're going to be adding diagnoses that can improve the severity of illness, because that's how these DRGs improve. So in this case, we'll keep the blended rate the same, $7,000. And again, APRs have a relative weight, in this case 0.8204, and that times a blended rate of 7,000 would be $7,542 in reimbursement would be expected for this inpatient encounter, reimbursed under APR DRGs. Moving to the next slide, we have added that mild protein calorie malnutrition as a secondary diagnosis, E44.1. And you can see on the screen there under the SOI column that you can see that applicable SOI rate of 2. And another little disclaimer is just because an individual diagnosis has a score of 2 doesn't mean your overall total score up at the top elevates to 2, but in this instance it actually does with the methodology for APR DRGs. And so the weight has then correspondingly increased to 0.9167, and that times the blended rate. Now our DRG expected reimbursement is improved to 6,417. Not as much of a jump in reimbursement that we saw in MSDRGs. Again, there's 4 levels within this APR DRG methodology versus 3 in the MSDRG, but you can see definitely some improvement in payment there. Moving on to add the MCC. Yes.
Sandy, can I ask you a question about that quick? When we're looking at the calculation there, if there's any other CCs or MCCs that impact the severity of illness, that would get added on, right? And that could change the dollar amount as well. I mean,
Absolutely.
in addition to malnutrition. Okay, so
Absolutely.
we see how malnutrition can impact that, but if there are other ones, then we would want to know that as well, which would be an easy report to get, because then you can still show that malnutrition made a little bit of an impact.
Yeah, absolutely.
Okay.
And the way
Cool.
that you would, the way you would calculate that, and this is how APR methodology is not as set in stone as MS. Like, we know what moves MSDRGs as HIM coding CDI professionals. We learn. CMS publishes those rules to us, so we know what makes movement in DRGs. APRs, that's proprietary to 3M software. They've developed this and it's licensed through them. And so they kind of hold a lot of that information close to their chest. So the way that we learn what impacts APR DRGs is really, you have to put it into the APR DRG grouping software. So what I would do in a case is I would have this case all coded out with all the patient's comorbidities, hypertension, diabetes, all of those things would already be there. And then I would get my baseline DRG and SOI score, ROM. And then what I would do is I'd add that malnutrition and say, okay, now by adding malnutrition, what impact does that create? Does that create another bump in my SOI? And then I know it's the malnutrition that's pushing it over, from a SOI perspective.
Right,
So,
over the top. Yeah, I know that question is on a lot of people's minds, because we get the MSG and the APR DRGs, and those are the ones we see most often. So thank you for sharing.
Yeah, because in MSDRGs, if you have a case that doesn't have a CC and you add a CC, you already have movement. Like, the DRG is going to move positively. Same is true as no MCC. I've added an MCC, it's going to move. APRs, not. It's not as black and white. So here's the example of adding the severe protein calorie malnutrition to the same scenario, the E43. And even though the SOI is 4, that individual diagnosis code, you can see that the overall, which is in that blue bar there, the overall severity of illness for this case is now sitting at 3, and it didn't bump it all the way up to 4, right? Because you'd need some more weights of other significant conditions to get it to that 4. But moving it up from a 2 to a 3 increases the relative weight, little better jump from 2 to 3 than it was from 1 to 2, and it's 1.3396, and with that calculation with the hospital's blended rate, you end up with over $9,000 in reimbursement. So you can see how this reimbursement methodology works as far as improving the reimbursement for APRs by improving your severity of illness score. So looking to some of our rules of our game, some recent coding advice that has come out, and we have a lot of rules that we have to deal with as coding professionals in when we're working with diagnoses and procedure codes and getting to our final DRG assignment. And one of those resources that we use, in addition to our published coding guidelines, which are I think we're at 114 pages right now of inpatient coding guidelines, which include our conventions and chapter specific and coding guidelines, but then also the American Hospital Association publishes quarterly what's referred to as the coding clinic. And so over the years, they've published many publications on the subject of malnutrition, and these are the most recent. So in third quarter of 2017, this is pages 25 to 26, they clarified the indexing for severe malnutrition. We know back in ICD-9, there was some indexing issues that attributed to a lot of miscoding of malnutrition. To 260 at the time was the ICD-9 code for kwashiorkor, and it ended up putting a lot of people in at risk of OIG recovery activity. And so here's a question, and these are questions that are submitted from coders across the country, or anyone can submit a question to them. And so the question was, can they assign that E40 or E42, which is now a new code for an intermediate malnutrition, or they call it marasmic kwashiorkor. But does those codes, would they be assigned for a diagnosis that was documented as severe malnutrition? And the answer is no. And that goes back to what we refer to as a coding convention. Malnutrition, when you look in our indexing in our ICD-10 classification system, it's then further subclassified as degree, and in this case it would be severe. And you can see there too that protein calorie malnutrition is in parentheses when looking at the indexing there, and it equates to the E43 code, and that would be the more appropriate code for severe malnutrition, and that the provider wouldn't have to use the term protein calorie malnutrition, or if they use the term protein, it wouldn't lead to the E40 kwashiorkor like it did previously, based on the improved indexing that we see in ICD-10. So in this case, they're just clarifying that, and it goes back to indexing, and that's our electronic tools, our 3M encoders, our Optums, all the other tools, TrueCode, all those that we use should be set up based on the indexing from that book. The next one is emaciation, and we see that physicians may document that a patient is emaciated, and that isn't an index term in our code book. And so if we look up that term, again, a non-essential modifier, meaning the physician could or could not use the terms associated with it, and that is due to malnutrition. In our index, it actually leads us to E41, which is nutritional marasmus, which has MCC status, whether or not the physician said it was due to malnutrition or not, or if the physician specified whether or not, it was severe, or if it was nutritional marasmus. So this answer is to clarify, and this is a source that we have to, that we look to as coders and CDI professionals to get to the most accurate code assignment, and that we're kind of held accountable to when they clarify, and hopefully they will improve the indexing and follow up to this as our codes are updated every October. But in this case, they're saying, no, you wouldn't code that E41 malnutrition code, that you would actually code cachexia, an R64 code, which is a symptom code. And that code actually has CC status versus the E41, which has MCC status. Because when you get to the index, and get to a code, our coding rules tell us now we have to go confirm it in the tabular listing, and under E43, this code is nutritional marasmus, and if the physician truly didn't indicate that that was the diagnosis for the patient, we shouldn't be making that code assignment. So that would likely be one of the terms. If we saw that in documentation, as CDI professionals and encoding professionals, we're going to start looking maybe for nutrition-related diagnoses, but we're not going to go directly to E41 and make that code assignment. Cachexia is the correct code without further clarification. Oh, clinical validation. You know, this is really a hot topic in our industry right now. And, you know, it really kind of has been since 2013 when the concept was introduced for the recovery auditors. But, you know, just to step back at a little history, because, you know, this was well publicized in hospitals, you know, all over the country were making some big payments back to Medicare and other payers. But the OIG got involved, and every year the OIG publishes their work plan for the year. And what was on it several years ago was the diagnosis code of 260, Kwashiorkor for ICD-9. And what was happening because of the way that the indexing was in the classification system, if it just said protein malnutrition, it would get you right to 260, which is an MCC, and which is truly the code for Kwashiorkor. And so this was a you know, something that was somewhat of an oversight in the indexing, and then it followed through into all the encoders and groupers, all the software systems that we use when we're doing our code assignments, our computer-assisted coding tools and all of that. So with the OIG, when they got involved and they started reviewing, is, you know, they found in many cases that it was not intended to be, you know, severe protein calorie malnutrition or Kwashiorkor or anything that would be of MCC status, and they started recouping lots of money from hospitals. You know, follow-up studies from this said that really from calendar years 2006 to 2014, that the government really estimated that they could have saved over $100 million had they pursued all of the 260s that they were seeing as lone MCCs in the populations of claims that were submitted, you know, based on their analysis of the Medicare database, referred to as MedPAR database. And so, you know, while they did recover almost $6 million, they you know, it's just really a small percentage of what they could have based on this coding and indexing error that that was discovered and acted on by the OIG. Many times it was not intentional, but now their efforts have really changed, and you know, what they're looking for now, as of January of 2018 this year, is now they're going after severe malnutrition. So, you know, they just see such a prevalence of it in the population. Many times it's the lone MCC that's driving the higher weighted DRG reimbursement. So now this year on their work plan is, you know, they're not seeing the Kwashiorkor anymore, the E40 codes in our ICD-10, because that indexing has been corrected. But now they're really looking at the clinical validation of the severe protein calorie malnutrition. So, you know, we expect to start seeing some of these auditing efforts popping up. What's nice is, nice or not nice, is that the OIG publishes all of these reports. So when they audit a hospital, and once they get through the final reported status, you know, and the full outcome and the hospital's appealed, all of that gets into a nice report that's publicly reported and available in the OIG's website, and it's available for you and I to look at. So that's one of the things I like to do, right, is read OIG reports and see what they're going after. My guidance.
I think it is important, you know, Sandy, like that you shared. I'm glad you shared it with us, because there's a lot of question about that, wondering like, well, what do I do and how do I appeal? And those are great examples. You know, it shows everything from both standpoints of the OIG and the hospital as well. So that's a great tool.
Right, it really is. And I've included one in this presentation because there's one hospital, you know, sad for them that they were audited and you know, publicly reported. And I'm okay to share it with you because, again, it's publicly reported information and available to everyone. But what I think is so important, and you'll see as we go forward, is the hospital just did a stellar job defending their case. And in that defense, they've provided just a whole lot of research and references that you and I can use when we're appealing denials. And so, you know, kudos to that hospital for the efforts they made, and you and I can all benefit from it. We don't need to all reinvent the wheel, right? Related to DRG validation versus clinical validation, I really want to make it clear the distinction between the two is that when payers, you know, primarily Medicare, you know, with the recovery audit activity, but now with all the Medicare managed care companies out there, you know, they're commercial payers, you know, I say they act like Medicare, but, you know, because that's what they're contracted to do, is to take care of a Medicare population in a managed care setting. And so they have to do their own type of auditing and recovery activities. So we just see, you know, hospitals are just being bombarded with you know, denial letters and cases that they have to appeal. And there's two on the inpatient side related to coding. There's two ways that a case may be denied. And one might be a DRG validation, meaning, you know, the case is coded incorrectly based on the merits of the case. So doctor didn't document that diagnosis, or the doctor did document it, but the way that the doctor documented it and specified it, we coded it incorrectly. So it's all about, you know, the technical piece, the coding piece, based on you know, our review of the medical record and determining what could be coded and what code should be assigned. Clinical validation is different. And if we move on to the next slide, how that differs is this is more about, you know, doctor said there was a diagnosis of malnutrition, but they're saying, you know, we don't see evidence that the patient really did have malnutrition. Doctor said the words, so you coded it, but we're not seeing that the patient really did have that condition. So in essence, they're questioning the diagnoses, the validity of the diagnosis based on you know, what they're seeing for clinical evidence in the medical record. And so that started in 2013 with the RAC's scope of work, where they made that distinction, and where this new kind of denial methodology really started. You know, how you defend that in an appeal is a little bit different, you know, because now you really need to look to the clinical evidence and what criteria is being used, you know, to support that evidence. You know, like think about other conditions like acute respiratory failure. You know, that's another one that is frequently targeted. You know, if you see a patient with that diagnosis, but you see that they've never been on oxygen greater than 2 liters, and that's their baseline anyways, you know, you might start to question that. And some of it makes a little more common sense, and people can rationalize that easier. Or if you see that they were intubated and put on a ventilator and moved to ICU, like people go, wow, yeah, that's a, you know, full-blown acute respiratory failure. But then there's this area in between as well that may still meet criteria, but whose criteria? Like, who makes up the criteria? Well, for some conditions, there's published national criteria that is well recognized in the industry. Some hospitals make up their own internal, like, here's the criteria we're going to use to support this high-risk problem-prone diagnosis or procedure. Malnutrition, we have criteria, right? We have Aspen. So what is it that we're, you know, what is it that the industry recognized? And you know, some of these payers, they make up their own and they don't let you know what criteria they're using. So, you know, it's really challenging, and I can't say that we've really fully got a handle on it yet. But I do know that from a clinical validation standpoint, we typically need to involve more clinicians in that appeal process versus the coders, right? Because the DRG validation is where the strength of the coder comes in supporting that and appealing it. But it's the clinical validation where we really need to look to our care teams in our clinicians. So that's, been a challenge for all of us.
Well, and you hit the nail on the head when you spoke to the, I'm sorry, I'm hearing a little bit of feedback. When you hit the nail on the head when you said payers are making up their own criteria, because we see a lot of that, and hospitals are appealing and say, no, we're using our best practice guidelines, we're using the Aspen Academy characteristics, or some people use the subjective global assessment, and that's where that that note that we're writing is so important, and to be able to provide some kind of communication through the electronic health record to get that into the progress note of the medical record is important.
Right. And, how I view the dietitian's note, or, the nutritional team's assessment, their ongoing notes, where they're going in and they're, working with the patients, their work. Yeah, all of that. When I look to those notes, I look to them no differently than I look to pathology reports, X-ray results, other documents, other diagnostic documents that are, physicians are using to make clinical decisions and to get to a diagnosis. I look to those nutritional assessments in the same light. It's just as important as that pathologist pathology report when it comes to diagnosing, a malignancy. So when I educate physicians, I tell them, I said, just like you look to your x-rays and your pathologies, look to your nutritional assessments, or, in the case of wound care, look to your wound care team to assist you in getting to that most accurate diagnoses, because that is their expertise. And that's why we consult them, right? And involve them in the care of the patient. And what you're seeing on the screen is just validation from our national association, as recent as December 2016, related to clinical validation and to not only assure that the case was coded correctly, but that it supported clinically, it is just as important. I kind of call it reverse querying from a CDI perspective, because, CDI kind of started, like we're seeing clinical evidence in a record, but we're not seeing an associated diagnoses. And now the reverse is true. We see an associated diagnoses, but we're not seeing the clinical evidence. Are we missing the clinical evidence? Is it there and it's just not being documented, or is it really not there at all, right? So it's a little different viewpoint when it comes from a CDI perspective, and then how that translates into final coding. Moving on to denials and appeals, I get cases where I'm actively participating in the appeals of certain denials, and this is just an example of one. Here's one, and here they say according to consensus criteria, the severe protein calorie malnutrition is defined as a BMI of less than 16, clinically significant weight loss, and characteristic clinical signs. So in this case, because this patient didn't have a BMI of less than 16, and they're saying that's what their criteria is. And they quoted, Aspen as well, but in this case, they're saying, even though the severe malnutrition was documented, there was insufficient clinical evidence in support of documentation in the record available to substantiate. So this is a case where they're saying we're gonna take that back and deny that MCC and lower the reimbursement in this case. This is a true case. I wish I knew the outcome. that this came from a commercial payer, actually, an Aetna managed care Medicare case. So, we really have to dissect these and say what criteria, and then try to disprove their criteria, or to say, in spite of your criteria, based on this, that, and the other thing, we still feel that this patient clinically was severely malnourished, and that it warrants the MCC diagnosis. So going on to the next slide. Again, this was the reference that was associated with that. So this is the consensus statement that they were referring to, as well as the Aspen and then also some World Health Organization information and so forth. So you really got to look to these denial letters to see what it is that they're using, to make that basis. Here's that appeal to the OIG that I was referring to from Vidant Medical Center when they were audited for severe malnutrition. And, you can go to this link and click on complete report. And if I remember correctly, there's like 32 or 33 references that this hospital cited that they were using to disprove, some of the findings of the OIG and to support their diagnoses and documentation on these cases. So I got to tell you, it's worth the time and effort. Anyone who works in appeals related to malnutrition, this is a go-to document, and I wanted to make sure you had it available. Moving on to the next slide, some other things that this is actually from that letter or from that OIG report. And here it says, they are even quoting CMS, who says, our nutrition professionals are the experts, and that we need to look to their involvement in the interdisciplinary care team and how vital that is to getting to a nutrition-related diagnosis. So anytime I can quote information right from CMS back to CMS, it's really helpful in an appeal.
I love this slide. I think everybody should save this one and just share it at any meeting they go to. Physician education and coding, and I think that's great to have that.
Yeah, and this came right from that appeal. So kudos to that hospital there. I also always like to throw this one in there too, whenever I can, because this is from our coding guidelines. This is the definition of an additional diagnosis, and typically, it's as a secondary diagnosis that these conditions are being denied. And so this is telling us that, to meet the definition of an additional diagnosis, if it's a condition that's clinically evaluated, if it's treated, if diagnosed, diagnostic procedures. And you see how it says or, right? It doesn't say and. So, did it impact the stay in any way? What I see is they're turning over the malnutrition, but they don't do anything to turn over like the hypothyroidism and the history of congestive heart failure and all those other things where, those aren't being as actively treated, right? But they're targeting on those ones that are being impactful from a reimbursement methodology. Then also moving to the next slide, I like to also include this because it was a new coding guideline, actually part of our conventions. In section 1A19 is, a couple years ago, they added this to our guidelines, and it says the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient, and code assignment is not based on the clinical criteria used by the provider to establish that diagnosis. So, there was some other rationale behind this coding guideline, but I still like to put it back at our payers in an appeal process to say that the physician really is the one ultimately responsible for diagnosing.
Yeah, and I was thinking about that, Fanny. Even looking at that, yes, they're definitely the responsible one, and CMS does speak to us as the nutrition professional, as dietitians, and when we coach dietitians, we talk about our PES statement, the signs and symptoms part of that being the clinical validation to support the malnutrition diagnosis. And the physicians, when we educate them, they look to us the same way CMS does as the nutrition professionals, and they say, okay, so are you using these characteristics, or are we using them? Like, no, you're using them as a reference, what we're using, but this is what we're assessing with. And so it's interesting to see that that the provider is sufficient. So does that mean that that still means, though, you need the clinical validation, right? It's not like the physician can just write severe protein calorie malnutrition. It's a done deal. Yeah. You still need that clinical validation.
Yeah, I would call that a surprise. Like every once in a while, I reviewed an entire record. I get to the discharge summary, and then all of a sudden a diagnosis pops up that you didn't see coming at anywhere, right? Like you didn't see evidence of it throughout the record, and all of a sudden, boom, severe protein calorie malnutrition on the discharge summary as a final diagnosis. You question that, right? Like, was it an error on the part of the physician? So you really do, especially if it's impacting your DRG assignment, right? Then you really have to be cautious. So, we do have to, be considerate of the clinical evidence. Many hospital policies are going that way from a coding perspective, is, before a coder can code, some of these high-risk problem-prone diagnoses and procedures, we have to make sure that, certain criteria is met. If not, we have to go back through a channel of, confirming that diagnosis through a query process with our physicians before we could make code assignment. So, it's part of our world now. It's been for several years. Not every coder is, maybe aware of all the criteria, and so education is needed there. That coordination and collaboration between CDI is so important. Sometimes, it's like, do the coders, is the information being readily made available to them during their chart review when they're doing their final code assignment? Hopefully that nutritional assessment is right there in available in the computer assisted coding tool or in their doc review or whatever method they're using to analyze their records for code assignment, making sure that that's readily available to them so that they can see the evidence.
Right, and if they know where to find it, and to also, we've learned when working with hospitals, when we do the education and training, remember all of our offsite coders too, and include them on the education that we're doing. The ones here in the country and other countries. I remember doing an offsite coding education and training for a group in India, and that was the coding team. There was one person on site at the hospital. So yeah, to be able to share all your resources, and thank you for that information, because it is a team approach. So as we wrap up, just our points, gosh, I feel like I just could sit and listen to you more, because I even learned a few things again every time we talk. So I'm sure that our attendees did as well, but it is definitely a team approach. So when we're working with hospitals, we want to make sure as the leaders in the malnutrition, caring for malnutrition, that we're constantly in communication with CDI and coding, and whether it's via reports or interdisciplinary team rounds or daily rounds, or just however you communicate with them, but from the first step in your program, and then continuous education. And the same thing I will say with physicians as well. You just don't educate them once. You have to keep going back, and we've all learned this, to communicate in all different ways of communication. Best practice, use your best practice nutrition tools, and be confident in confidence, and follow up on denials and appeal. I should have put an appeal, but follow up on denials and know when they happen and appeal. And I've talked to a lot of dietitians that don't even know, and hopefully their coding teams are coming to them for that help with the appeal letters. We've worked with a few hospitals. I remember, not recently, but I know a few years ago, at that time, all the hospitals we had worked with had at some point, an audit, and they all passed. And but in the last 8 years, I've had calls from places we worked with that have had to appeal, and we helped and coached them through that. And I've called you, Sandy, for help too to see it. And are we doing we're getting every step we need? And like you said, if payers have different guidelines, we're going to see those appeals, and especially if the OIG is focusing on severe protein calorie malnutrition. So I'm just going to put another, stake in there for the nutrition-focused physical assessments, because there still are teams that aren't using them or don't feel the need to use them, or kind of been trained but not super comfortable, so they use them on half the people. It's a best practice tool. It needs to be used on every person you do a nutrition assessment on. You need to be trained confident, because that is a huge piece of that patient care. It's going to tell you a lot more when you're doing a physical assessment. Plus, for your intervention and about the patient, you'll find more malnutrition that way if you're doing it appropriately and correctly, and it supports that diagnosis. It's a huge support of that diagnosis. So that's my little plug for the physical assessment. And we're advocating, of course, for best practice in patient care, and make sure you collect data. Collect your data and your accurate data. You saw today, Sandy shared some information about MSDRG and APR-DRG, that reimbursement piece. We collect and we look at the SOI and the RLM scores. We look at the prevalence of malnutrition percentages among admitted patients. We collect and report data for hospitals on all those areas, including the reimbursement. And we're going to get to questions because I know people have questions. They're just popping in all over, so I'm getting there. So we'll answer some more, and it'll actually probably hit on some of these points as well. So, gosh, thanks. I feel like, you know, we could just, like I said, keep talking about, there's just so much to learn, but I think it's really important as a dietitian and coding professionals that are on this webinar today. So valuable information. So thank you, Sandy. So we're going to go ahead and get some questions here. So I'm going to go ahead, if you haven't already typed them in, make sure that you did, and I'm sure the people who really wanted to ask them have got them in. Boy, we have a lot. Okay, so we're going to scan through here. Let me just give me a second. Yeah.
Let me just intervene here for one moment. First off,
Please
thank you so much, Sandy and Michelle. Friends, we have crept up on the 1 hour mark, but this was such good information and such important, valuable stuff that it's important that that you guys hear all of it. We know that your time is valuable. So if you do have to jump off the line, don't worry. We are recording this webinar, and you will receive a link to view the recording of the webinar if you need to jump off. If you're able to stay on with us, Michelle and Sandy, let's go ahead and do about 10 to 15 minutes worth of questions, because there's a ton of questions here. I don't think we can do them all, but let's do a handful of them, and those that we don't get to, we'll answer them and then email them to the group in the post-webinar email. Sound good?
Awesome. Yes, and here they're still coming in. Yep.
All right. So go ahead, Michelle, okay. And yeah, go ahead with the questions.
Okay, excellent. There's a question about the slide that you showed, Sandy, and talking about, is BMI of less than 16 necessary to identify a patient with severe malnutrition? And then there's another one up here that said in one of the denial letters we shared, it was criteria. So it's not the Aspen Academy guidelines. It's showing what the payer, the insurance company, was saying was the guideline. The insurance company was saying for severe protein calorie malnutrition, we use the characteristics of a BMI less than 16, and I don't know what other ones are on there, Sandy, but that was the question. We don't want people to get confused. That's not part of the Academy and Aspen guidelines. That's just what the payer was saying that they used, correct?
That is correct. That was what the payer was saying was that they were using for criteria. And so that case didn't meet that criteria. So that's what they were using, even though the patient had a percentage of weight loss recorded over a certain period of time and, you know, things like that. They're saying, well, you know, and as we know, you know, patients of all BMIs can be malnourished, right? So, you know, that's the criteria that Aetna in that case was applying. And so that's where it would take, you know, involvement with you know, your clinical team there to say, what criteria do we use as an organization, and how does our record support that in this case, that it did meet our criteria, and then try to disprove their criteria, right? Like with evidence that says, you know, not only, you know, patients do not have to have a BMI of less than 16 to be considered severely malnourished.
Correct, right. Excellent. Okay, the next question, what information can the clinical nutrition team expect the health information HIM department to share? Are reports available to HIM department to pull information on malnutrition reimbursement? So this is like a two-part question, and I'll answer, well, I can answer both, and Sandy, you can share too, your thoughts on this. But typically when we work with dietitian teams and CDI, we get them all in a room together. We provide education and training on the malnutrition focus of the program, what our criteria is that we're using, you know, where we're charting. They know where we're charting typically. They're already talking before we, you know, get to the hospital. They all know each other in most cases. But we typically end up like pulling a report, or they're emailing when they find malnutrition. Or some of the teams just say, no, we're looking at the dietitian notes all day long. We don't really need an extra report. So those are different ways the dietitians might, you know, communicate with the CDI. And in terms of reports available, coding HIM, they can pull reports based on coded reports. They can query and set up queries for, malnutrition diagnoses. Typically, your IT department can pull reports right out of your work doc flow sheets, depending on your electronic health record for what the dietitians are diagnosing. The reimbursement piece, most hospitals get kind of stuck and challenged on that, and that's where we work with different departments to capture what their reimbursement is, and that's what we provide as a service through DM&A. And people usually just get stuck on knowing whether malnutrition is the only comorbidity or not. So that's a piece that we help assist hospitals and in the service we provide. Sandy, any other tips on how the dietitians could do a great job communicating with CDI or coding, things that they'd want to share?
Yeah, I mean, you've covered a lot of them, Michelle, and the fact that, there just needs to be some collaboration between the teams so that, everyone's aware of what information is needed to clinically support these cases, how the physicians are going to access this information and act on it, to carry it through to a diagnosis and carry out the treatment plan. And related back to what coding can do, to support nutritional services is, we do have data. Every time that we assign a code, it creates a discrete data element that we can use to pull data from, reports from. So if you wanted to get a list of all your patients in your population that have particular nutrition-related diagnoses, that information is very easily obtained through simple reporting tools in our coding department. So, we just all have to be working together, especially on those appeals. That's really where we can come together and do a lot of collaboration.
Right, because if you're reporting on something that got denied and you don't even know it was denied or you haven't appealed on it, you can't really report on those numbers and say you got them. Mm-hmm. So you want to make sure you know the denials, and yes, that communication is key, and that you're appealing. So. Right. And hospitals, seconding what you're saying.
Yeah, hospitals usually have, a department or certain individuals that are responsible for managing appeals. So, many times they have their own internal reporting capabilities as well, so that they can quantify how many denials are we getting related to this diagnosis, and what are our outcomes of our appeals, what's been successful in appeals, and then keep repeating that, and hopefully having success with multiple payers with the same type of appeal methodology.
There's some questions in here. There's a couple of them that kind of all have the same answer in a way. They talk about the characteristics and guidelines. So I'm just going to take all three of them and kind of just answer them as a whole. So there's a question about albumin in physicians, and there's a question about mild malnutrition examples that you use, Sandy, and then about physical assessment, and do you need that in your diagnosis of malnutrition? And so speaking to the mild malnutrition, the Academy and Aspen guidelines, we're just diagnosing moderate and severe 14-calorie malnutrition. I haven't seen any mild, but like Sandy said during her presentation, hospitals can come up with criteria for what they want, and insurance payers can have criteria as well. I haven't seen any, best practice, evidence-based or research-based criteria to support mild malnutrition, but it might get coded based on coding clinic guidelines. Anything to add to that, Sandy?
No, and you're right. Based on criteria, more likely you're going to get to a moderate or to a severe. Mm-hmm. But what happens is, in our queries to our physicians, when we ask for specificity, we have to present them with multiple options, related to severity, and it may be selected as mild, or the physician may just, choose to use that terminology when documenting it. So, because there is a code for it, and it, based on the physician documentation, we would apply that code.
Thank you. And then regarding albumin, we're not using it to support the diagnosis of malnutrition. It is not a criteria that we use to support it. You can look at it, you can trend it, but it's not part of our 6 characteristics that the Academy and Aspen has validated using for the diagnosis of moderate or severe protein calorie malnutrition. So, you know, you're looking at it, you're a clinician, you're paying attention to it. You might document a low albumin, but it's not part of those 6 criteria that you're using to diagnose malnutrition. And I want to clarify, dietitians in the United States do not medically diagnose, we nutritionally diagnose. In Australia, they medically diagnose, awesome. But in the United States, we nutritionally diagnose. So that medical diagnosis that gets coded is coming from the physician, and that medical diagnosis for malnutrition or any diagnosis has to be in the progress note and the discharge summary. Those are the places we like to see it. Like Sandy mentioned before, not just in the discharge summary on the way out the door, because that's not going to get supported. So no, we're not using albumin. And, you know, we do a lot of education and training on that for those physicians who are still kind of stuck wanting to use it, or clinicians. I just actually met with a group of physicians a few months ago, and I had a couple, or one new one really challenged me on the albumin, and it was a great conversation, and they ended up agreeing in the end. So really you just got to, you know, educate, support, understand where they're coming from. You know, we kind of put them there way back in the 80s. And so we're just having to re-educate, and we do that training with the teams as well. And in terms of the physical assessment, that's part of the 6 characteristics, and so you need 2 of the 6. And so if, you know, some dietitians are just using intake and weight loss, like they're using their EEE, or estimated energy expenditure, and weight loss as their criteria, and they're like, oh, I'm done, out for 2. But again, I encourage you, like, get your hands on those patients, because you're going to find a lot more. One of my favorite quotes from a good friend and colleague that I worked with a couple of years ago at a hospital system, she said, man, all those patients I missed. She had been a dietitian at that time for about 14 years. And I said, well, you did what you knew was best then, but now you know more now, and you can use better tools. And so, you know, we're finding a lot more and caring for our patients better. So remember, we have intake, that's estimated energy expenditure. We're looking at that. We're looking at weight. We're looking at, and this is just off the top of my head, I don't have my my characteristic card in front of me. We're looking at edema, hand grip strength, fat loss, and muscle wasting. Did I get them all? I said weight loss. So those are what we're looking at. So good questions there. I think we have time for like one more. We're almost hitting the 15-minute mark. Let's see if there's one that we can get here. I know there was a question. Oh, here you go, Sandy. Will recovery auditors acknowledge Aspen and Academy's consensus statement malnutrition criteria as the clinical validation, or you know, as the criteria? Have you seen that?
I haven't seen that they haven't.
Right. Okay. Good. Well, that's good.
Yeah. I mean, they still, again, depending on the recovery auditor and the criteria internally that they're using, you know, it still might be a battle, but you know, it is more recognized today than it was years ago, right? And
Right.
the awareness has been heightened, and it's you know, I think that you know, most of our nutritional assessments now speak to all of those characteristics as the clinical evidence. And, you know, I still think it's the go-to to use in an appeal against any third-party payer.
Because you've seen it work, right? Yeah.
Right.
Okay, so we have 2 more we can get to. How do we confirm that the estimated reimbursement is what the hospital actually received? That's something that, you know, we do a lot of work with, and you can work with your HIM, you can work with your business office, your decision support, revenue cycle teams. Those are the teams that we would work with in the hospital. And I just had a great conversation with a colleague down south, and we were talking about this, and just, you know, educating on finding out if you can figure that out. And that's why we made it such a service in our division, the nutrition division, because hospitals, the time it takes to develop a process and or to be able to drill down to that dollar value and how malnutrition impacted it. It's a time factor, it's a labor factor, it's a setting up a process that they're coming to us for that service. So there's some places I know that are doing that, some bigger health systems. I know that there's an article the Academy published, and I know we've sent that out, and I saw it on the CNM listserv this week. So that went out about how to get to that. And this is actually a question on the listserv this week about how to get to that actual. And a lot of people are getting soft numbers. I can tell you that we're getting more hard numbers just because of the data that we're collecting. So it's looking at what your hospital is getting in. Do you have denials or appeals out on anything? And then was malnutrition the only comorbidity, and how did it impact that base rate like Sandy showed the examples of? So complex, but, you know, just talking to your hospital. And if you're not able to, then, you know, connecting with others and contacting us if you need some help in that. Okay, I think that's going to be it for questions now, just so we can, you know, respect people's time. It's 2:15 Central Time. And so we're going to go ahead and do our question for our, I think that's, oh, the next thing, sorry, we'll talk about good to best, and then we do have a giveaway at the end here. So hang tight. Yep. But thank you guys for your questions, and we're going to get to as many as we can, and we'll email out those answers.
Exactly, Michelle. We'll answer all of your questions and include those in the post-webinar email. But let me talk quickly about Good to Best. It is not too late to sign up for our Good to Best conference, which takes place in a little bit less than a month at March 16th through 18th at the Paradise Point Resort and Hotel in San Diego. It's 3 days of inspiration, motivation, education, and networking with your peers in a casual and relaxed environment. Or if you just want to get out of the cold and come to San Diego, that's good too. It's 17 CEUs, and as you can see there on the screen, we have some great keynote speakers. And if you want to see our other list of topics, you can go to our website at goodtobest.org. The hotel is filling up, so if you are interested in attending Good to Best, I suggest that you register as soon as possible. And as a special for attending this webinar for first-time attendees, I'm going to send you a link for 50% off registration. So the registration fee will only be $100 to come to Good to Best, which is a great deal.
What a deal. Yeah.
So Michelle, go ahead and your webinar contest question.
Okay, so my contest question is, what two pieces of data are important to track when working with the APR-DRG based insurances? So what two pieces of data did we talk about that are important to track and look at when working with the APR-DRG based insurances? So the first three people that email that question will receive a free complimentary 20-minute coaching call from the nutrition division on whatever it is you need. And you can email that to me at Michelle, M-I-C-H-E-L-L-E at destination10.com. That's Michelle, 2 L's, M-I-C-H-E-L-L-E at destination10.com. And so the first three people that send me the answers will get a free 20-minute coaching call from our nutrition division. And just a little bit more information about DM&A. We're so thankful you signed on today, and we're really happy with the turnout that we had. It's just great to see all these professionals out there wanting to learn more and grow. And so we can help you in many areas. We do operational assessments for food service and nutrition and EVS. One of our biggest tools of service that I got to actually work in for a good 3 to almost 4 years was the room service, and implementing room service, doing room service tune-ups on site. We provide coaching and education and training, so you remain self-op, and whether you're in self-op or a managed area, we can help you with your room service and bringing it from good to best, and increasing your patient satisfaction scores. And room service, which you probably saw in the February 2018 recent JAND that came in the mail. It talks about room service and intakes and malnutrition, and that was written by our colleagues at, or Sally McRae, our colleague at the Mathura Hospital System in Brisbane, Queensland, Australia, who also will be speaking with me on the prevalence of malnutrition at Good to Best this year. Excellent article in combination, or in partnership with Seaboard. They wrote that article, and it's wonderful. So room service, gosh, if you don't have it, definitely something worth looking into. Interim staffing, we provide those services as well as contract to self-op in food service and nutrition. We provide uniforms for our food service teams that get them looking sharp and just feeling good. We also have our own food service web-based system called Stella, Cloud Solution, and more. So just to give you more, we do a lot with, what I tell you, with the most passionate coaches out there, working with others to be able to bring the best patient care and customer service to your team. So thank you all for attending. I'll let Bernard go through the rest.
Yeah, thank you, Michelle. And Another special that we're offering to our webinar attendees is, you don't know what you don't know in your department. And so we're offering a $500 off an operational assessment. If that's something that you think that your department needs or could use, I want to put a link in the post-webinar email. And for webinar attendees, $500 off an operational assessment. So by tomorrow,
Awesome.
you will receive, by tomorrow you'll receive a post-webinar email from us, which will include the presentation handout, your CEU certificate for one CEU, a webinar recording if you want to view it again or share with your colleagues, a link for 50% off registration for Good to Best, and a link for $500 off an operational assessment. And yeah, look out for that from us tomorrow.
Thank you, Bernard.
Yeah, you're welcome. And friends, if you have any immediate needs or require any support whatsoever, please don't hesitate to contact us for a free consultation with Michelle or one of our other excellent success coaches. There is no obligation to have a conversation. We are here to serve you and to help you become successful. Thanks once again to our presenters, Sandy and Michelle, for this wealth of information, education on caring and coding for malnutrition. Both of you did an amazing, excellent job. On behalf of Sandy, Michelle, and myself, thank you for attending our webinar. Have a blessed day. Goodbye, everyone.